Well, actually, the famous David Speigel is at Stanford, as you all know, but he's done more to advance my career than any other factor I can think of. And I'm going to talk tonight about obsessive compulsive disorder. And I'd like to start with this magazine article advertisement that I came across recently. It says, "Obsessive compulsive prone to antisocial behavior, have we got the shoe for you?" Not one of our standard treatments, but obviously what they're referring to here are personality characteristics that are kind of public, general population terms. And we don't mean this at all in obsessive compulsive disorder. In fact, there's very little relationship to these kinds of personality traits and real OCD. OCD, as you all know, involves obsessions that are intrusive thoughts or images or impulses that a person finds difficult to resist. And this is some data on 250 patients just showing the types of obsessions that are that people present with. And the thing I want to point out is that by and large, the majority of people have contamination obsessions and pathological doubt. And that would be doubt that they turned off an appliance or locked the door, or doubt that that bump that they hit on the way into the office was a pedestrian they ran over, and so on. And so this would be associated with a lot of checking behaviors. And there are other types of obsessions here, and you can see that 60% of people have more than one type. And that's a factor when we go to treat these people because we often want to address these different types separately. On the list here is somatic obsessions, and this gentleman, Tom Avery, has a somatic obsession. It says Tom Avery's recurrent fear is that his brain will get real small and roll out of his right ear. That would be his obsessional thought. And as you can see, Tom has a compulsion which relieves his anxiety, and that's to put his finger in his ear to keep his brain from rolling out. It's locked in a fairly logical way to his obsession. And many compulsions are tied in this logical way with the obsessive, people obsessing about contamination concerns often involved in washing rituals, and people with pathological doubt often involved in checking rituals. But sometimes these links between the compulsion and the obsession are very tenuous. A person, for example, walks through a door and thinks of a relative, and his concern then is that some harm will befall this relative unless he walks back through the door repeatedly until it feels okay. And if you ask that person how his walking through the door can provide any protection against his relative, he'll say, well, I don't know. It doesn't make any sense to me, but it just, I can't help myself. I've got to do it. Why take the risk? Less common obsessions or compulsions, but ones that make the news would be like hoarding, where people pack their houses with things, old trash and garbage that they just can't throw away lest there might be something valuable in there that might be needed later. And again, about half of these people having more than one type of obsession, or compulsion rather. Now, OCD hasn't changed very much in DSM-4. But one difference is that we've added a poor insight type. It used to be that insight had to be maintained in order for you to make a diagnosis of OCD. And it's still required that insight is present at some point in the course of the illness. But we now recognize that about 5% of these people will lose insight as time goes on and will actually come to believe in their obsessions and in the urges that they have with almost an obsessional tenacity. And we can now make that diagnosis of OCD if insight was present previously and has subsequently been lost. And one of the interesting things that we want to look at is now whether these people respond differently to treatment than people with garden variety OCD. There's some suggestion that they may. Now, one of the things that's happened recently is an attempt to see if we can find subtypes of OCD that may have some implication for either genetic transmission or treatment response or course of illness. And there have been several attempts to do this, and a couple of subtypes that have emerged from several different approaches, whether you just look at clinical descriptions or whether you do factor analyses of checklists like the Y-box checklist. I'll present for you. The first is harm avoidance. People that have their main concern as harm avoidance or concern that the environment presents some threat to themselves or loved ones in their family. And these are people that largely have contamination and pathological doubt obsessions and engage in washing, checking, and cleaning compulsions. The interesting thing about these folks is that, as you might imagine, they have high levels of anxiety associated with their concern about the threat in their environment, and they have a lot of comorbid anxiety disorders. And if you look at these kids as children, you often get a history of behavioral inhibition as children. That is, these are kids that were shy in novel situations, didn't like to meet strangers, they would hide behind their mother's skirts. And we know that children that have this temperament have a tendency to develop anxiety disorders as they age. And one of the anxiety disorders that they develop is OCD. Now, I want to point out one other thing about this, and that is, if you remember the bar graphs I just showed, this is the great majority of OCD patients. They fall into this subtype. And that means that the treatment outcome studies, and much of what we know about OCD, in fact, comes from a study of this subtype of OCD. We really don't know nearly as much about other subtypes, and it's likely that other subtypes may not respond as well as this subtype. So just kind of a caveat, when I'm presenting later some outcome data, just keep in mind it's outcome data really that's largely made up of these folks. Here's an example, pyromaniac's on vacation. She says, you got to go back home right away, Arnie. I forgot to leave the stove on. And of course, in an OCD patient, it would be, go back home. I may have left the stove on. I may have forgotten to turn it off. But this would be that first subtype. And here's another example. This is Elliot Zambini, a member of the Flying Zambini Brothers Circus Act. And you can see Elliot just cannot resist the urge to pick up this speck of lint on the stage, thereby disrupting the act. And that's the kind of difficulty these people have. They just cannot resist carrying out these compulsions. Now, I'll say that there are exceptions to that. I had a woman who was a school teacher who had a contamination obsession that revolved around particles of the Catholic communion wafer that she believed, if she would pick up a speck of this, she would have to wash. And anyway, she was a school teacher, and she would go in and spend hours before class began washing the desks of students that may have been Catholic, doorknobs, and so on. And yet she could play bridge every Wednesday night with a group of Catholic women and handle cards, and it didn't bother her at all until she got home, and then she had to wash and take off her clothes and everything. But there is this ability to kind of delay rituals often, and that makes it hard often to detect these people because they can function perfectly normally when people are around, and then when they get on their own, they really get caught up in their rituals. Now, the second subtype is people that have to have things perfect or just so. These people need to have things in a certain order or symmetry, or have to repeat things, like the gentleman I mentioned walking through the door would have to go back and continue to go back and forth through the door until it felt right, until he felt that his relative would be protected. These folks have less anxiety generally. They don't have much in the way of comorbid anxiety disorders. They're more likely to have compulsive personality traits, that is, this kind of driven, perfectionistic personality, rigid personality trait, have difficulty when things don't go exactly as planned. And the other thing that's really interesting about this group is you find a lot of comorbid tic disorders, including Tourette's syndrome, in this group of people. And there's some evidence that there may be a kind of a subtype of OCD that runs with Tourette's, and there's even some evidence that it may be passed as an autosomal dominant gene, in which the females in the family develop OCD and the males in the family develop Tourette's syndrome. And there's also some good data now that this subtype of OCD doesn't respond as well to standard treatments. And it's in this group that the addition of a neuroleptic agent may be particularly helpful, not just for the tics, but also for the OC symptoms. Now, here's an example of this subtype of OCD. Somebody with this has obviously been to the library and arranged all these books. And their closets would look the same, you can imagine. Here's another example. This is a fellow who's put his OCD to some functional use. He's become an efficiency expert. But as you can see, when he heads off for work in the morning, the dysfunctional side of this becomes apparent. Says Edwin's losing some of his spontaneity. Well, as you know, OCD was discovered in the ECA study to be far more prevalent than anyone had imagined, with approximately somewhere between 1.5% and 2.5% of the population interviewed in their homes. These aren't clinical patients. These are people interviewed at random in their homes, meeting DSM-3 criteria for OCD. Why don't we see these folks in our offices? I mean, we don't. This is the fourth most common disorder, psychiatric disorder, in community samples. Certainly isn't the fourth most common disorder in our clinics. Why not? I think a lot of it has to do with shame and people's unwillingness to describe their symptoms, even to a psychiatrist. We have a patient that came in for a treatment for a panic disorder in our clinic, and we treated her and followed her up for several years. And after about 4 years, she said, "Oh, by the way, I've had this other problem all along that I haven't told you about." And we screened for this, but she said no originally. And then after 4 years. Now this is a woman who wasn't concerned about the stigma of seeing a psychiatrist or getting into treatment or filling out insurance forms or whatever. And yet OCD somehow was enough more embarrassing to her that she wouldn't tell us about that, even though she was accepting treatment for panic disorder. I think in addition to just the kind of shame that's involved, another reason that we don't diagnose these people is because the majority of these folks have other conditions along with their OCD. It's really exceptional for patients to have OCD as their only psychiatric illness. And very often it's the other disorders that become the focus of treatment. And I'll just mention, this is a group of about 500 patients showing a breakdown of some of the more common comorbid conditions on Axis 1. And over half of these patients also have Axis 2 diagnoses. But let me just say a couple of words about the overlap with depression, because that, I think, is one that really obscures OCD. As you can see, in this group, about a third of them have comorbid major depression. And if you look at past history of major depression, you pick up another third. So the coincidence of OCD and depression is much, much higher than would be expected on the basis of chance. And if you, here's some data from general medical practices and also from mental health clinic populations, looking at the prevalence of OCD in different populations. And this is just the general patients coming into a primary care setting with the kind of community prevalence rate of 1 to 2% of patients having OCD. But if you look within the group of patients coming to a primary care setting for treatment of major depression, there are 2 studies now that have done this, both showing about 10% of those patients have a current or past history of OCD. So, and of course in mental health clinics where we tend to see the more severe cases, it's over 20% of our major depression patients that have a history of OCD as well. So if you're not seeing these people, a good place to look for them is in your depressed patients. That's where they're probably hiding. And it may be difficult to distinguish OCD from depression because there's a lot of overlap in the way these, the complaints that these patients have. These are some of the kind of symptoms that are present in both disorders, and obviously you can see ruminations, indecisiveness can be clearly in both. Neglect of hygiene, one that we typically associate with depression. In an OCD patient, if they happen to have a contamination concern and engage in washing and cleaning rituals, it may be that they will neglect showering or washing because they know once they start that process, it's going to be 3 hours before they can get out of that shower. And so they'd rather go dirty than get themselves caught into this obsessional, or ritualistic process. Disturbed sleep, again, classic in depression. But in OCD, it's often the time when obsessional thoughts collapse in on people. They lie in bed, there's nothing to distract them, and they just obsess. Particularly doubters have a lot of trouble with this. I have a radiologist that I'm seeing currently who has to get up often in the middle of the night and go back to the office because he's obsessing about some film he read that maybe he missed something, and he'll go back and check it, and then he'll come home and go back to bed, and then he'll get up and go back in again to reread the film or redictate the report because he just, he doubts that he's read it accurately. Weight loss, again, common in depression and OCD. We see it sometimes in patients that have contamination concerns for fear that perhaps there's a contaminant in the food that they're about to eat, and so they'd rather not eat than to pick up this contaminant. So I think even when we're aware that you're looking for OCD, very often the symptoms that the patient is presenting for will look so much like depression that that's the thing that comes to your mind first. We're trained to look for depression. We know that suicide's a risk, and so we're much more likely to, I think, make this diagnosis in the presence of symptoms like this. Well, it says, Joyce, how much do I charge people when I don't know what's wrong with them? I'm not going to say anything more about diagnosis. Let's assume you've made the diagnosis of OCD, and let's spend the rest of the time talking about treatment. So we'll step inside the OCD clinic. Just knock 8 times before entering. This would be which subtype? The second subtype, just perfect or just so, right? And let's talk first about drug treatments. Now, until about 1990, we didn't have any effective treatments in this country for OCD. And 2 things happened in 1990 or thereabouts that really changed the face of our practices with regard to OCD. One was the publication of Judith Rappaport's book, The Boy Who Couldn't Stop Washing. I don't know if you've read this book or not, but it's a story, it's a collection of stories written by her patients, and she's a child psychiatrist at the National Institute of Mental Health, written by her children and their parents about their disorder, which was OCD. She originally intended to write this book as a technical book for psychiatrists and therapists, and her publisher had the foresight to suggest that she write it for the general public. And as you know, it became a bestseller, and she went on the talk show circuit, and all of a sudden the population became aware of this condition. And simultaneously with that awareness, on the market came this drug, Anaphronyl, clomipramine, which came onto the market with advertisements promising this new powerful medication to stop intrusive thoughts and acts. So not only did we have the recognition of a disorder, but now we could offer some sort of treatment to these patients. Well, how good was this new powerful medicine? Well, I'm not going to belabor these data. You've probably seen them before, but this is a collection of data from the 2 large studies that were submitted to the FDA for approval of Anaphronyl for the treatment of OCD, comparing Anaphronyl in red with placebo in the yellow. And you can see there's very little placebo response, which is unusual in psychiatric disorders. It tends to be one of the peculiarities of OCD that they don't respond to placebo. But in Anaphronyl, with Anaphronyl treatment, you see a gradual decline in obsessive compulsive severity. This is a scale which has become kind of the standard now for measuring OCD severity, the Yale-Brown Obsessive Compulsive Scale, also known as the Y-box. And it's a 0 to 40 scale, and you can see these patients start out fairly high on this scale, and there's a gradual improvement over time. Now, I want to make 2 points about this data, which I imagine you've seen before. One is that this kind of improvement takes 10 to 12 weeks to level off. And that's of concern because when we started doing studies with this, the assumption was this was an antidepressant. It's a tricyclic antidepressant, Anaphronyl, and we assumed that people would probably respond as depressives respond to this drug in about 4 weeks. And so when they didn't respond in 4 weeks, we upped the dose. And when they responded in 8 or 12 weeks, we said, you need a higher dose to treat OCD than you do depression. Now we know that isn't the case. And in fact, the fixed dose study with Prozac that was looked at 20, 40, and 60 milligrams found almost, there was just slight, you pick up just a few percent, but basically nearly everybody that's going to responded at the 20 milligram dose. So if we had just waited, people would have responded anyway. And I think that that's good news for us because side effects become a problem when you get up to higher doses of these drugs. And so if you don't have to go up there, that's great. We typically in our clinic now will start people on a drug, and we reassess them at 4 to 6 weeks, and if they have shown some sign of improvement, even though it's small, we won't change their dose. We'll leave them on that dose until the improvement levels off, plateaus. If they haven't shown any sign of improvement at all by, say, 6 weeks, then we'll raise the dose. But even just a few points on the Y-box scale is encouraging enough for us to leave them on the first dose. The other point I want to make about this is that although clomipramine was better than anything else we had, this kind of levels off here, and we're only seeing about a 35 to 40% improvement in symptoms, which is good for many patients. For many patients, it's a difference between a functional existence and not, but it's a far cry from cure of this disorder. Well, what was different about anaphronyl and the other tricyclic antidepressants that have been on the market for years before that? And the answer is that it had effectiveness in blocking the reuptake of serotonin. And we now know that this is the neurotransmitter that seems to be most important in the pathogenesis and treatment of OCD. And since clomipramine came out on the market, we have seen the introduction of several drugs that focus specifically on blocking reuptake of serotonin. We now have 4 of them on the market, 2 of them, fluoxetine and fluvoxamine, approved by the FDA for the treatment of OCD, sertraline currently in for approval and under review. These drugs, as you recall, were introduced with this promise of being breakthrough medications, breakthrough in this case for depression, but you know that the breakthrough was not in terms of their effectiveness. These drugs are no more effective than the predecessor drugs that had been out for years. The breakthrough was in terms of their tolerability, that is a side effect profile, their ease of administration. You don't have to worry about blood levels. You don't have to worry about toxic side effects and so on. And of course, their safety was a big advance over the existing tricyclics. So, but in terms of their efficacy, they really aren't any better. In terms of OCD, we have very little information comparing these drugs with anaphronyl. Clearly, anaphronyl has become the gold standard against which other medications should be and are measured. And you may have seen this meta-analysis that John Greist and colleagues published in the June issue, I think, of the Archives, American Journal of the Archives, looking at the data that was submitted to the Food and Drug Administration in seeking approval of these drugs for the treatment of OCD. Now, these are studies with anaphronyl, with Prozac, with Luvox, and with Zoloft, all of which have done pivotal studies in OCD. And the important thing to remember when you look at this article is that these drugs were not compared with each other. They were compared with placebo. We don't have any head-to-head comparisons. But since they all use the same measure of severity, that Y-box scale, it makes sense to look at how much improvement occurred. And this data suggested that anaphronyl may be somewhat better. This is improvement on the Y-box scale here. So it's the opposite of the graph I showed you before. Up is better in this case. And it looks like clomipramine has some advantage over the 3 SSRIs that kind of group together. There's some problems in interpreting this data, one of which is that these drugs came along later, and about a quarter of the patients that were included in these trials had already had a trial of anaphronyl and had failed to respond. So it might have been a treatment less responsive group. But that may not account for the whole thing. It could be that there is some advantage still. There are very few trials in which these drugs are actually compared with each other. There are 2 of them that I'm aware of. One, a very small trial comparing anaphronyl with Prozac, in which anaphronyl seemed to have perhaps some slight advantage, although there were patients that responded preferentially to Prozac as opposed to anaphronyl. There were patients that responded the other way around. And the other trial with a larger group of patients comparing anaphronyl and Luvox. And in this study, you can see that these drugs look almost identical in terms of their response. At this point, I guess we can best say we need to have more studies to compare these drugs head-to-head to see whether there might be an advantage to anaphronyl. Its major disadvantage, of course, is in terms of its side effect profile, which is typical of tricyclic antidepressants. Now, there are some differences among the SSRIs, and I just want to mention a couple of them that I think are clinically significant. At least they're things that we concern ourselves about. And one of those is in terms of the elimination half-life or metabolic half-life of these drugs. And here the difference is basically Prozac against the other three. Prozac and its active metabolite norfluoxetine having much longer half-lives than the other SSRIs. Some people may consider this to be an advantage with regard to, say, a self-tapering action when the drug is discontinued and so on. We find that it's more of a disadvantage for us for a couple of reasons. One is one of the troublesome side effects we have with these drugs, these serotonin-active drugs, is on sexual functioning. About a third of the patients that are treated with Prozac will end up with either inhibited sexual desire or inhibited sexual response, which in the short run isn't a problem, but in long-term treatment really begins to be an issue for family harmony and so on. We've tried all sorts of techniques for offsetting this problem. We've tried giving amantadine and yohimbine and buspirone and a number of other drugs, and nothing really works very well. Sometimes we have patients responding to one or another. One of the things that's often helpful, particularly if sexual response is not completely blocked but is just kind of suppressed, is to give patients a day or two off drugs. And often you can take them off, say, for the weekend, and they'll recover enough functioning to be able to have sexual relations over the weekend, then you restart the drug after that. And you can do that with short half-life drugs, but with Prozac that's not an option available to you. So that's one of the reasons that we find it a little bit more difficult. The other thing is, if you're changing drugs around, which we often do with OCD patients, it's going to take several weeks for Prozac to wash out. And again, so that's going to slow down your ability to be switching drugs, and that might mean that you'd want to start, at least if you want to try Prozac as one of the drugs, you might want to start with a shorter acting drug first, and then if it doesn't work, switch to Prozac as a later option to save yourself a little time. Now, the other difference that's received a lot of publicity among the SSRIs is in their ability to inhibit various enzymes in the cytochrome P450 system. As you know, the cytochrome system is a system that's in many organisms, bacteria, insects, fish, mammals, and there's several hundred P450 enzymes that have been identified, about 20 of which are present in humans. And basically these enzymes have the responsibility for metabolizing toxins, presumably toxins that were ingested in a diet, but now in addition toxins that we administer as drugs to patients. And 5 of these 20 or so odd human P450 enzymes are involved in metabolizing many of the drugs that we give our patients. These are the 5. And one of the differences among the SSRIs is in their ability to inhibit one or another of these isoenzymes. The ones that has received the most publicity is 2D6, because 2D6 metabolizes drugs that have low therapeutic indexes. That is, if the concentration climbs too high, these drugs can present problems for patients. Those would be like the antiarrhythmics and the tricyclics. And 2D6 metabolizes those drugs, and so drugs that inhibit that enzyme potentially could cause problems when you administer those kinds of drugs to patients along with an SSRI. Sertraline and fluvoxamine have much less effect on 2D6, although they affect some other isoenzymes. And I guess the point to keep in mind is that none of these potential interactions would be a reason not to use a particular drug. But it is something you need to be aware of when the patient is receiving other medications that might be metabolized by one of these enzymes. And here are a few examples of drugs that are metabolized by these various enzymes. And depending on what your patient is taking, you might either want to check blood levels or reduce doses or perhaps use a different medication. These are the ones that tend to be more difficult, but you can see 3A4 is involved in metabolizing halcyon and Xanax, as well as erythromycin and Seldane, and warfarin over here, and so on. So just kind of be aware of it, but don't necessarily steer away from these drugs because of this. Well, should you give these drugs to your dog? Well, if the dog has this condition, acrylic dermatitis, it might not be a bad idea. Acrylic dermatitis is a condition that certain breeds of dogs have in which they lick away the flesh of their paws and expose often tendons and sometimes even bones. And that condition has been likened to trichotillomania in humans, the compulsive hair pulling condition, which is considered by many people to be an OC-related or OC spectrum disorder. And it turns out that the serotonin reuptake inhibitors are helpful in dogs with this condition, and also in some people with trichotillomania and other compulsive type disorders, compulsive gambling and so on, eating disorders and so on. But be careful, because the primary disadvantage or the primary side effect of these drugs is nausea, and so you can give your dog some nausea. Well, if the first-line drugs, the SSRIs and clomipramine, don't work, we have a variety of things that we can do to help boost effectiveness. One of them is to add another agent to a first-line drug in the hopes of boosting the response. And these are some of the agents that have been reported in one study or another as having some effectiveness. I should say that in large group studies, rarely do these augmentation strategies produce significant differences. But for individual patients, maybe 1 in 10 patients, this may make a big difference. And so it's worthwhile to try some of these augmentation strategies. Clonazepam and buspirone, we tend to consider those drugs in the first subtype of OCD, where there's a lot of anxiety and comorbid anxiety disorders. These can sometimes be helpful in those people. Lithium, I think, generally favored in people that have substantial depression that hasn't responded to the serotonin drug. Pimozide and haloperidol, both neuroleptics, useful in people that have comorbid tic disorders or psychotic symptoms along with their OCD, often being very helpful in those patients where the first-line medication alone may not be. These last two, fenfluramine, which is appetite suppressant, and adding serotonin drugs, can be helpful in some patients, but you need to be careful that you don't get a serotonin syndrome with these drugs, which can happen sometimes. Third choice in your treatment strategy when augmentations don't work is to consider drugs that we typically wouldn't give as first-line drugs or as treatments alone for OCD, but in certain subtypes of OCD patients, these appear to have some efficacy. Phenelzine is a particular interest. Alone in OCD, the monoamine oxidase inhibitors are rarely useful, but if you have OCD that's comorbid with social phobia or with panic disorder, sometimes a monoamine oxidase inhibitor will help not only the social phobia or panic disorder, but also the OCD. In a patient like this, a trial of phenelzine as a standalone, you wouldn't combine this with an SSRI or Anaphronyl, but as a single treatment might be worth a try in those folks. And there are isolated reports that clonazepam and buspirone have been helpful as a single agent in some patients. And then there are some unconventional or novel treatments, largely experimental at this point. I think the first 4 on this group are of interest. They relate to a subtype of OCD that's been described by Sue Sweeto recently in JAMA, in which OCD symptoms follow a streptococcal infection. And the assumption is that in some individuals, the anti-strep antibodies cross-react with neurons in the basal ganglia and can cause an autoimmune form of OCD. Actually can result in tics as well as in OC symptoms. And by the time these symptoms appear, often the strep antibodies are gone. So testing for strep antibodies may not produce anything. And penicillin, a course of penicillin, often, particularly in kids that have had repeated strep infections, is sometimes worth doing. Down the line, we get into some more controversial types of treatments, including phototherapy for seasonal OCD. IV clomipramine has been useful in Canada, not so useful at Columbia in the United States. ECT in patients that have marked depression along with their OCD. Well, Dr. Neptune says send in the next 3 patients. I don't want you to get the impression that we treat everybody with drugs, and so I wanted to say some words about other types of OCD treatments. And of course, behavioral therapy is the one that is most clearly demonstrated to be effective and the one that I'll talk about. And the type of behavior therapy that's useful in OCD combines exposure therapy, which is commonly used in treatment of phobias and panic disorder, in which patients are exposed to cues that cause them to obsess. We want to make them obsess. And then we couple that with response prevention, in which we assist the patient to refrain from carrying out the ritual that makes them feel better. It's this combination of provoking the obsessions and having them refrain from ritualizing that constitutes behavior therapy for OCD. And this is some data now that's been out for about 10 years, but still quite current, showing how effective this type of treatment is. This is something over 200 patients treated in different settings, all with exposure and response prevention. And the point of it here is that about half of the patients that are treated with this approach achieve at least a 70% improvement in their symptoms. And another 40% or so achieve a middling amount, somewhere between 30 and 70%, and only about 10% don't have at least a 30% improvement in symptoms. If you average all of these patients together, the average improvement is about 60%, compared with, say, 35 to 40%, the best outcome we can get with drugs currently. So it appears to have a little bit of an edge over drug treatment, although there are problems with this kind of treatment as well. This is a patent I took out of the Peoria newspaper describing these things called sanitary doorknobs, which are really paper cups, sort of like cupcake cups, that are impregnated with an antiseptic solution. And people can slip these things over doorknobs and not come in contact with germs. I don't know who's making these, but I know who's going to buy them. There are patients. So there is this reluctance often on the part of patients to engage in behavior therapy. And if we look at those folks as well, we get a slightly different picture when we look at efficacies of treatments. This is some data that I've put together from a number of different sources, looking at what would happen to a hypothetical group of 100 OCD patients that comes in and is assigned to receive either drug treatment or behavior therapy. And what this shows is there's a certain amount of attrition that occurs right off the bat, either refusal of the treatment or dropout because of side effects or whatever. We lose about 1 out of 4 patients that come in for treatment by drugs, and another 30% or so will not improve sufficiently to be considered responders. And that's really a very conservative, very modest cutoff. Depending on the study, it's a 25 to 35% improvement. And there'll be about a third of these patients that don't improve even that much on drugs. So we end up helping maybe 45 out of the original 100 patients if we set out to treat them with drugs. And of course, the main problem with drugs is if you discontinue the drugs, the vast majority of those patients will relapse within a few months of going off the drug. But as long as you keep them on, they do well. On the other hand, if you set out to treat these people with behavior therapy, we'd have a somewhat larger attrition initially, refusal or dropout. But those who completed treatment would do pretty well, only 10% roughly not responding. So it looks like we, again, help those two things sort of offset each other, and we end up helping maybe just over half the patients that we set out to treat in this way. Again, not a very impressive kind of outcome when we think about diseases. And it's kind of led to some notion that maybe we ought to consider combining treatments, that if you have two different treatments that are each partially effective, and that work presumably through different mechanisms, one at a biological or chemical level, one at a psychological level, that perhaps the combination of them might be better than either treatment alone. And John Nemaya called this quote to my attention recently. John, the former editor of the American Journal of Psychiatry, the quote says, "It will be easy to perceive the errors and partial views of such as profess to apply a medicinal agent only, or of those who advocate a course of moral treatment only for a cure. There's no doubt that a cooperation of medicinal and moral means is requisite to effect a thorough cure." Now, this could have been said at the latest APA meeting, probably was in some other paraphrased, but it was written nearly 150 years ago by William Neville in his book on insanity. Well, this is the watchword now. People believe this is true, and what is the evidence that it is? Who recognizes this gentleman? Rasputin, yes. If you recall your Russian history, you'll remember that Rasputin was a Russian peasant and self-proclaimed holy man, a monk, who worked his way to a position of considerable influence in the court of Tsar Nicholas I. And by all accounts, he was a very eccentric man. Many people considered him insane, probably would have been diagnosed insane, mentally ill, by our current terminology. And as you might expect, someone in that position had a lot of enemies within the court, and they tried on several occasions to assassinate him, always unsuccessfully, until finally he was invited to a midnight tea party in his honor. He was fed poisoned wine. Now, the wine didn't kill him, and when he realized what was happening, he bolted from the room, ran into the courtyard, he was pursued, and he was shot twice. He still didn't die. He was seized and dragged down to a frozen river and stuffed through the hole in the ice, and he finally expired. And what does that have to do with this talk? Well, it's the earliest case example I can find of combined chemical, surgical, and behavioral interventions for mental illness. And it clearly demonstrates that the combination succeeded where individual treatments failed. So it gives us some hope that maybe there is some truth to this notion. Well, there really are only 3 studies available that have looked at this. 2 of them done by this gentleman. Anyone recognize him? This is Isaac Marks, probably the world's most prominent advocate of behavior therapy, several hundred publications on behavior therapy, exposure therapy. Isaac is celebrating not his publication record, but the fact that he's just treated his fear of heights by climbing this mountain in Norway. And here he is at the top in the red, obviously looking very pleased with himself, as indeed your patients who do behavior therapy will if they complete it. Isaac did a study in 1980 and another in 1988 in which he compared a combination of clomipramine and exposure and response prevention with placebo and exposure and response prevention. And what we're plotting here is the percent of baseline time that patients spent engaged in rituals. And starting at 100%, and you can see that there's a 4-week drug or placebo run-in here, very little change in ritual time, and then exposure is added, and marked decrease occurs during that 4-week period. But you'll see that the folks that got the clomipramine along with exposure have a somewhat earlier and greater response than the people who got placebo. And if you look at their depression scores, you see also an advantage. Obviously, this is an antidepressant drug, and we're starting to see antidepressant improvement within 4 weeks, as we would expect. And again, the difference favoring the combined treatment. Now, this was a relatively depressed subgroup. 15, I think the mean score on the Hamilton was something around 18, actually, when all patients were included. So it's a moderately depressed OCD group. Marx's second study in '88 was with a non-depressed group, but he found the same results. They weren't quite as marked. Behavior therapy caught up a little sooner, but basically what advantages there were favored the combined treatment. There wasn't a single measure on which exposure therapy was better than the combined treatment. And a third study was done in 1990 by Coutreau in France, using fluvoxamine as the agent again with exposure and response prevention, and found the same results essentially that Marks did, favoring the combined treatment. But in addition, Cotrot's study gives us the best follow-up data we have on what happens after drugs are discontinued. And Cotrot looked at that in two ways. He looked at how many patients required any further intervention at all for their OCD during the first 6 months after the study was over. And at the end of this study, the drug was discontinued if patients were on drug. Behavior therapy was stopped if they were getting behavior therapy. So they got no further treatment after the study. So if they required some further intervention, they were classified as having that. And then he looked also, a year after the study was over, at how many patients were now on drug for their OCD. He had three groups. He had a group that received the drug only, a group that received placebo plus exposure, and a group that received fluvoxamine plus exposure. Here in the red is the group that got the drug only, and you can see the high relapse rate that we typically see with patients treated with just drug and then the drug is taken away, 55% requiring some further intervention, 60% on that graph doesn't look right, does it? Back on drug at a year. Here's the group that got placebo plus exposure. 40% requiring some additional intervention, mostly in the form of further behavioral booster sessions and so on. 18% on drug a year after treatment. Those are the treatment failures, essentially. But look at this. The folks that got the combined drug and behavioral treatment, nobody requires any further intervention during the first 6 months after the study ended, and 18%, the same percent that got behavior therapy only, are on drug. So it suggests that combining behavior therapy with drug treatment substantially reduces relapse after the drug is discontinued. And it looks from these, kind of looking at these studies together, that you can get the advantages up front, particularly in depressed OCD patients, of perhaps an earlier and broader response to combined therapy without having to pay the price of higher relapse when the drug is discontinued. Now this is early data. We have very little information, and we need more studies to confirm this. But so far, that would be kind of the conclusion you draw from the existing studies. Now, when everything else fails, neurosurgery is kind of our last resort currently. And since you have someone here that's done some neurosurgery, some lobotomies for OCD patients, I thought I would say a few words about this procedure. This is not what we do. What we do in neurosurgery for OCD can, I think, best be appreciated by looking at this PET scan data that came out in the January '94 issue of the Archives. These are PET scans of patients that were first scanned while obsessing and then rescanned while not obsessing, and then the two scans are subtracted. So what you see here is the difference. This is what happens during obsessional activity. And that PET scan is superimposed over an MRI, so you can see some of the structural landmarks here. What this shows is that during obsessional activity, we have hyperactivity in the orbitofrontal cortex, that is a part of the frontal lobe that lies just over the eyes, in the caudate, particularly the head of the caudate, and some other structures as well, the anterior cingulate and the thalamus. Now, these regions of the brain all have projections from the raphe nucleus that are serotonin-rich projections. And the notion is that these structures may be linked in sort of a loop fashion, and the theory has been put forward that the caudate nucleus may play a role in gating signals into this loop, or regulating, modulating the activity in this loop. And that maybe in OCD, the caudate nucleus falls down in its job, and one gets kind of an echoing or reverberating kind of a positive feedback loop here. At any rate, these findings give us kind of convergence of the data that we have from drug studies that implicate serotonin, because all of these regions are rich in serotonin nerve terminals. And also, with regard to the surgical interventions that we make, it's the connections between the orbital frontal cortex and the caudate nucleus that are cut during neural surgery. And there are several places where you can do that, and there are different types of surgical interventions. capsulotomies and limbic leucotomies and cingulotomies and so on. This is a kind of device that used to be used for this kind of procedure. These are the actual lesions. Here you can see these tiny dots here. This is a capsulotomy patient, I think 8 years after the capsulotomy was performed. And you can see these tiny little lesions that are made that interrupt the nerve tracts in the internal capsule. Well, this gentleman, Per Mindus, at the Karolinska Institute in Stockholm, has collected a lot of data on neurosurgical procedures for OCD. And this is kind of what comes out. This is 379 cases, so this is a large sample. And these are largely patients who did not respond to normal treatments, first-line treatments, and whose condition was severe enough to warrant this kind of extreme procedure. And you can see that about a third of these patients were essentially symptom-free after the neurosurgical intervention, and another quarter or so are much improved. So this is a procedure that really is producing remarkable results considering the intractable patients that are referred for it. Now, nowadays we're using the gamma knife for this kind of procedure. The Mayo Clinic has one of these and is treating OCD patients. It allows us for the first time to do placebo-controlled studies of neurosurgical interventions. Before that, when we had to put burr holes in people's skulls, we couldn't do placebo studies. A placebo study is underway at Brown now looking at the gamma knife, and we'll have some better data as to whether this procedure is really as good as it seems to be. So let me just kind of summarize in a last couple of slides. This would be kind of the standard recommended course of therapy for OCD patients. Typically, we give them 3 trials of serotonin uptake inhibitors, at least one of which is clomipramine and the other 2 being selective serotonin reuptake inhibitors, and or we give them behavior therapy. In our clinic, about 3/4 of our patients get a combination, and about half of the remainder gets either drug only or behavior therapy only. If that fails, you then move to either augmentation strategies for your drugs or more intensive types of behavior therapy and/or more intensive types of behavior therapy. We have an intensive outpatient behavior therapy program in Peoria where people come and spend 3 weeks with us, and during the course of that 3 weeks, we see them for 2 hours every day for therapist-assisted exposure, and then we give them another 2 to 3 hours of homework therapy exposure to do on their own. And we get them to the most difficult task on their hierarchy by the end of the first week or the beginning of the second week. So it's really exhausting. And I know here in St. Louis you have an inpatient program, Alec Pollard's program, that does the same sort of intensive treatment on an inpatient unit. Those treatments failing, you would probably move to alternative monotherapies, considering novel treatments then, particularly if you have a case of seasonal OCD or a history of strep infections or so on. And lastly, neurosurgery would be kind of your last resort. Even so, you're going to have some patients that don't respond. And obviously you could be misdiagnosed, or you need to maybe treat them longer or at higher doses, or they might have a refractory condition that needs certain kind of augmenting strategies that you haven't considered. One of the interesting things, I think, has to do with continued avoidance or ritualizing. The 1988 Marks study included an arm in which patients were told, we're going to put you on this drug, and it's going to take it several weeks to work. So we don't want you to be unnecessarily uncomfortable while you're waiting for this drug to work. Go ahead and avoid the things that cause you to obsess. And if you start obsessing and feel uncomfortable, go ahead and carry out your rituals. Just make yourself feel comfortable and let the drug do its job. When those patients were brought back in and tested, the drug had very little effect. In fact, for ethical reasons, that arm of the study was concluded, and those patients were crossed over to an exposure plus drug arm. The implications for that is that it may be that continued exposure is important for the drug to manifest its benefit. And it may be that what the drugs actually do for the patients is allow them to engage either naturalistically or through planned exposure in an exposure kind of program. And if they don't do that, if they're continuing to ritualize even though they're receiving a drug, they may not have a good response to the drug. So it's vitally important, I don't think I can overestimate this, that if you're treating patients with a drug for OCD, that you include in their treatment plan exposure, whether it's done with a manual that they can read on their own and do, or whether you have therapists that you work with that can do this with you. It's an important component. Lastly, there are, I've talked exclusively about behavior therapy and drugs, and I don't want to imply that that's the only thing that's of use in OCD. We are hopefully looking at systems and patients in a broader context than just chemicals and behavior. And particularly in kids, we find that psychosocial factors can often be very important. There are kids, for example, who don't respond to your best efforts at treatment, and then you find out that there's abuse going on in the family. You correct that, and all of a sudden these kids become responders. Or there's marital conflict, and you get help for the couple, the parents. They work out their marriage, and the kids become responders. So these factors can certainly influence treatment outcome to a great extent. Well, this is Sid Baldwin. He continues to be nagged by a short attention span. I think this is extremely difficult after a great meal like this late at night to stay awake, and I appreciate that you've all done that. And I'm going to stop at this point before I see anybody in this condition.